grade of
Yes, sir.
dysplasia and the size
Yeah.
of lesion would affect.
Because I think that's the thing which comes in the biopsy report when we counsel the patient whether we can actually keep them on close surveillance.
Yeah. So high grade dysplasia would certainly attract my sort of attention and put a push more towards surgery, which I did, knowing very well that I may not be able to get a clear margin on dysplasia because it's a field change and I may still get dysplasia. But at least I will have that sample for a more closer examination and a biopsy. And even if it's a small one, I would still go forward because a small excision would not cause the patient too much morbidity. So again, if it is a low grade and clinical, I would put in a lot of clinical emphasis on that. Superficial, absolutely wide, in a low risk area, I would choose to follow up.
Okay. So,
Any other?
Like the option C you said, first after risk stratification, if it is into high risk, that is moderate or severe dysplasia, we would definitely go a little radical and solve the entire thing.
yeah. So basically, the dysplasia classification has brought in two things: the architectural features and the psychological features. The binary system, which basically categorizes them into a low risk and a high risk, non-dysplastic, mild, moderate, and with either 3 or 4 of the architectural and the psychological features, and high risk ones it's moderate and with severe dysplasia. So the general tenets of management of these lesions would be risk assessment, which comes through a biopsy and with a clinical examination. Habit cessation and counseling goes on side by side. Review the histopathology and of course surgical management. Now the whole lesion was excised, and this was the final path report came to us. It was a verrucous lesion with mild to moderate dysplasia, interspersed with well-differentiated squamous carcinoma. It was about 4.5 centimeters. But remember that we didn't assume that it was malignancy, so we just went about excising the whole dysplastic lesion there. All the margins are uninvolved, but you've got moderate dysplasia at the soft palate margin. So the question to the panelists is, seeing this histopath report, do you have any concerns? Would you want to go in and do something additional, or are you just happy keeping the patient on close follow-up?
So neck is not.
Yeah, the neck has not been addressed because this came in the final pathology report.
So then I would definitely go back and do a neck along with the excision of the moderate. It's better
Unfortunately, many pathologists label verrucous carcinoma under category of well-differentiated squamous carcinoma. Textbooks, verrucous carcinoma falls in the category of well-differentiated squamous. Because we've done a good amount of surgical resection and confident with it, a single modality treatment would be the choice, and keeping the patient in close follow-up rather than anticipating and going and doing the resection. Because this pathology report has to be taken into pinch of salt. Most of the basement elements are intact.
Would you-
This serious dysplasia is also labeled as verrucous carcinoma, which falls under the category of well-differentiated squamous carcinoma.
Would you want to address the neck?
I would keep this patient for follow-up, do screening of neck. If I have high suspicion, I will do a periodic follow-up for this patient.
Okay.
Yes, sir.
Sir?
This is a recurrent lesion, operated multiple times, of long standing, verrucous appearance, and finally we have a histopathology which says a well-differentiated squamous cell carcinoma. Even a verrucous carcinoma like Dr. Bola put in is a very well-differentiated carcinoma. Now I'll go back to my pathologist. Probably have a look at the slides also. If this squamous carcinoma are of nests with keratin in them, and there is no measurable depth which you can get. In many of them, you may not be able to find the depth of the lesion. These are very superficial cancers. Mostly they are interspersed in the scope of the rest of the body. There, the probability of having a neck node, I assume would be neck lesion. And I would probably not address them. Maybe keep the neck under surveillance with an ultrasound. But I would not go again for a bilateral change. I see this lesion is there on the
Yes,
side.
yeah.
It's going to be a sort of kind of an overpeak to go for even a verrucous carcinoma, a large verrucous. The probability of it going to the neck is very low. Having said that, there are textbooks textbooks which say that verrucous may harbor foci of squamous carcinoma, but it doesn't mean that those actually go to the knee and do that. So in this particular case, the general rule is that if you have a squamous carcinoma, do a neck dissection. But since we're doing a case discussion and one in which you see a few foci of keratic with squamous differentiation, I would not go ahead and go with that. And again, this margin, this we anticipate all the time.
Yeah.
And there may be margin, but that does not give you the liberty to chase the soft palate and resect the soft palate. I would keep the patient.
Vikram sir?
Yeah, I think in the field cancerization setting, it is very difficult to chase dysplasia. And in a normal looking mucosa also, you may see microscopic dysplasia. So unless there is a carcinoma in situ in the margins, it's very difficult to chase the dysplasia alone. So yeah, in a patient where you expect multiple recurrence, what is more important to have close follow and intervene at the earliest, both in terms of neck as well as the oral cavity.
So I think very good points is fine.
So in lesions like this, what is the role of looking at things like candida, peribasilar lymphocytes? Is there any evidence that might give us some risk stratification?
As of now, I'm aware nothing.
People have looked at all these things.
The
Yeah.
College of American Pathologists gives out guidelines on how to report your pathology specimens. There are others, but since we follow the US, I'm quoting the example of the US. So there are some mandatory criteria which need to be reported, and there are some additional criteria which should be reported at least in tertiary referral centers and teaching institutes. Lymphocyte invasion, what is called the pattern of invasion, and these are all additional criteria which you may not report in the lab. But it's a good idea to keep data for that in your lab if you are doing that, because as you said, they may be of prognostic implication. Number one, or it may help you to decide on immunotherapy treatments later at some point of time. So this data is only maturing. It's a good idea to keep that data, as you said, but we cannot take a decision based on that at this point of time with the given evidence that we have.
Because right now, we are only visually histologically looking at this. At a molecular level, what is happening with these lesions, we still really don't know.
Yeah, I think biomarkers would be there.